KPC Gandhi, the present managing director, a reputed forensic scientist. The objective of the foundation is to bring benefits of advanced DNA technologies to the common man. Incidentally, today is late Dr. Lalji Singh's sixth death anniversary. Friends, may I request you all to observe a few seconds of silence in respect of the soul. Friends, it is of paramount importance that clinicians are equally partners in the noble cause of bringing genetics knowledge to the benefit of people suffering from genetic diseases. Webinar series Genetics in Dermatology is a platform to initiate dialogue between clinical dermatologists and geneticists to bring awareness of genetics applications in dermatology. In fact, this has paved the way for helping more than 50 families with rare skin diseases in diagnosis, prognosis for better management and prevention. In some cases, precision therapeutic intervention is possible. Today, we will be discussing such a case wherein the genetic testing and finding the causative mutation for the disease Papillon Lefevre syndrome that led to precision treatment. Friends, I take this opportunity to welcome you all to the ninth session of the Genetics in Dermatology webinar series. I am glad to introduce Dr. Bhumesh Kumar, who has kindly agreed to chair the session. He is a very well-known dermatologist and pediatric dermatologist across both Telangana, Andhra Pradesh, as well as all of South India. Presently, he is associate professor and head department of dermatology, venereology, and leprology, Government Medical College Suryapet, and program director, Pediatric Dermatology Training Center, Gandhi Medical College and Hospital, Hyderabad. He is honorary General Secretary elect 2023 of the National Indian Association of Dermatology, Venerology, and Leprology. He has 35 publications in peer-reviewed journals, authored 12 book chapters, and presented more than 115 papers and delivered 300 guest lectures at various conferences. Organizing secretary for several national and international conferences. He is recipient of a number of prestigious awards. Friends, I take the pleasure to invite Dr. Bhumesh Kumar to chair the session. Dr. Bhumesh Kumar, please, the floor is yours.
Yeah, namaste to everyone, and thank you, Dr. B.R. Rao, for your kind words. I am humble. So, as a dermatologist, we know the dermatology broadly divided into two categories. That is one infective dermatosis, otherwise, second one is the inflammatory dermatosis. In developing countries like India, the majority are infective dermatosis. But last 2 decades, even the inflammatory dermatosis is in rise because of changing of lifestyles, because of westernization, and so many factors. In inflammatory dermatosis, more than 50% are under the category of pediatric dermatosis. So, being the pediatrician as well as the dermatologist, pediatric dermatologist, so I'm very happy to be associated with Genome Foundation. Myself to learn many things related to xenodermatosis, especially in the pediatric dermatology.
Yes.
So if we see the xenodermatosis, whether it is a monogenic diseases or polygenic diseases or a chromosomal disorders, so it needs a continuous research and updates because no updates, we all will become updated. So that's why we are here to update our knowledge in the dermatosis, which is very much essential for the confirmation of diseases, because the history and detailed examination is the king in the field of medicine. But when for confirmation certain diseases like genodermatosis, which needs to confirm by genetic testing and genetic analysis in an early stage for effective specific therapy, which will improve the quality of life by decreasing the morbidity. So this is our main motto to initiate, learn about this genetic conditions in the dermatology. Whether it is infective or inflammatory dermatosis, skin health awareness, because we all know skin is the first defense mechanism of our body. So the first, the skin health has to be initiated from the skin health, and that too, the skin health has to be initiated from the pediatric age, from the day one, because skin health is the body health is the global health. So let us sensitize the importance of skin health and to initiate early diagnosis related to xenodermatosis. Today, we have a eminent speaker, Professor Dr. Peter, to enlighten on PL syndrome more and more. So I request Dr. V.R. Rao to introduce the speaker and in further proceedings. Over to Dr. V.R. Rao.
Thank you, Dr. Domesh. I am pleased to introduce Professor Dr. Peter Eckroach, our distinguished invited speaker today. I had the opportunity of reading his articles in precision treatment approaches while we were dealing with papillon leverfred syndrome cases. When I have approached him, he has readily accepted to share his experiences in our webinar series. Let me briefly read his curriculum vitae. He was born in 1963. 1982-1987, completed dental school at the University of Cologne. 1988-89, he was captain of the medical staff in the German Air Force. 1989 to 1992, periodontal training at the Department of Periodontology of the University of Munster. 1992-2004, Department of Conservative Dentistry at the University of Heidelberg, and 1995 clinical director since 2000 head of the section of periodontology. He obtained his PhD in 1997 in habilitation. In 2003, obtained associate professor Heidelberg. Since 2004, professor of periodontology and chair of the Department of Periodontology at the Center of Dentistry and Oral Medicine, Johann Wolfgang Goethe University, Frankfurt. 2012 to 2014, managing director of the Center of Dentistry and Oral Medicine, Frankfurt. 2011 to 2016, president of the German Society of Periodontology. He is academic editor of PLOS One journal. His main fields of work: diagnosis and therapy of furcation involvement, regenerative periodontal therapy, local antibodies, long-term results after periodontal therapy, impacts of periodontal and other diseases. May I now request Professor Peter Eckroach to deliver his lecture, please.
Yeah, Professor Rao, thank you very much for your kind introduction. Thank you very much for inviting me to share my dental and periodontal knowledge with you. It's a little bit a clash of cultures when the dental knowledge meets the dermatology knowledge. However, you could view the teeth as a part or as an offspring of skin, of mucosa. Okay, could I please have my first the title slide so that I can start?
Got the title slide.
Okay. Yes, there we are. Okay, that's so, Papillon-Lefebvre syndrome, and I will concentrate in the periodontal part, in the periodontitis and its treatment. So if you consult textbooks on Papillon-Lefebvre, you may get the impression that Papillon-Lefebvre syndrome means tooth loss guaranteed, that people will lose all their teeth in early age. And please, the next slide. Yes, the periodontium, the periodontal tissues are a little bit discrete. So what you see over here, that's healthy gums. And we in the case of healthy gums, the soft tissue is filling the interdental gaps, and the soft tissue is reaching up to the crowns. You just see the crowns of the teeth. What you normally not see is the bigger part of the periodontium. You only see the gums, the gingiva. Next slide, please. So one slide further, please. Yes, and over here you now can see the bigger part of the periodontium. Pardon? Okay. You see the root cementum, and you see the fibers that connect the tooth with the bone. That's the support.
We could not see these slides. Yeah, now we can see.
Okay. So what you see is now, so it's like an iceberg. You only see the tip above the water, and underwater or beneath the gums, you have the root cementum, this gray layer on the root of the tooth, and you see the fibers that connect the tooth with the bone. And you see on the other side, on the left side, you see a radiographic image of a healthy person, of a healthy young female, where the bone reaches up to the crown almost. So this is the healthy situation. Please, the next image, one image further. So the teeth do not regenerate themselves. It's the hardest material in the organism. It's provided, and however the surface can be, the oral cavity is colonized by more than 400 to 700 species of bacteria. And the yellow layer that you can see now on the schematic drawing, this is bacterial deposits. And if you look to this clinical image, you may see at the gingival margin, you see these layers. Pardon? You see these layers of bacterial deposits on the tooth surfaces. And the tooth is, if so to say, a kind of a problem, because the tooth interrupts the integrity of the body and creates a potential entrance for microbiota into the inner part of the body. On our surfaces, on the epidermis, on the oral mucosa, in the gut, we have surfaces that are heavily colonized by bacteria. However, in the inner part of the body, we do not want to have them. We do not want to have them in connective tissue, in bone, or in the blood. The gums are where the gums connect with the tooth. There we have a potential entrance for bacteria into the inner part of the body. And so the organism, the body, had to create mechanisms to keep bacteria out. And the mechanism is an inflammatory mechanism. It's the inflammation of the gums. So mainly neutrophil granulocytes get into the gingiva, create an inflammatory infiltrate, and keep bacteria out. And this reaction is manifested clinically as gingivitis, inflammation of the gums, but simply the gums. Next slide, please. So gingivitis, how does it come? Next slide. So it's bacterial deposits. In this case, the deposits are stained with a reddish to bluish color. So you see them, the biofilm. In this case, it's a hard surface that is not renewed, and in all cases that you have a liquid medium, if you have humid conditions that are bacterial colonized and you have hard surfaces, then the creation of such biofilms can be observed. So next slide, please. So gingivitis, inflammation of the soft tissue, is just affecting the gingiva, the soft tissue, and gingivitis does not destroy the periodontal tissues. It's just inflammation. Next slide, please. How exclusively gingival inflammation. Next slide, please. However, if this inflammation has to stays over weeks and months or years without removal of the biofilm, then the homeostasis may change, and this is predisposed, especially in young people, by genetic impairment of the inflammatory reaction. This is what we will talk about today. However, behavior can influence the inflammatory reaction and can impair it. And if the defense does not work anymore, if the dams are breaching, then the body, the bacterial deposits will enter between the gingiva and the dental surface, and the body will destroy its own structures to prevent the microbiota, the bacteria, from entering connective tissue and bone. So periodontitis, if you want to, is a kind of a very rustic type of defense mechanism to prevent osteomyelitis, the infection of the bone that may be life-threatening without antibiotics. And this type of reaction was created in the human body many years before, or a long time before antibiotics were available. So this is a type of defense mechanism. The backside or the downside of this defense mechanism is destruction of periodontal support, of tooth support. Teeth get loose and may be lost in the end. So this is what we will deal today, or what we will deal about today. Next slide, please. So this now is periodontitis. You can see on the schematic drawing on the left side, you see the periodontal structures destroyed. The fibers are gone. The bone is gone. You have hard deposits on the root surface. You have still the inflammatory infiltrate. And on the right side of the schematic drawing, you still see the healthy conditions. On the clinical image, you see now a very, let's say, ugly example of periodontitis. You see a lot of bacterial biofilm on the teeth. You see the color of the gingiva does not look healthy. It's a violet, dark red, and the tissues have receded. You can see now the roots of the teeth and the papilla, the soft tissue in the interdental gaps has gone. So in this case, you may see on first sight that the patient is suffering from periodontitis, but this does not have to be the case. Next slide, please. It may be that the periodontal support is destroyed. Please, the next. You see in this example, you see that the gingiva still reaches up to the dental crown, to the enamel. However, if you put a probe in between the gingiva and the tooth, it reaches 8.5 millimeters down. So 8.5 millimeters of the periodontal structures, of the periodontal tissue, of the periodontal connection between bone and tooth have been destroyed. So the main examination that we rely on in periodontology is probing pocket depth, is measuring these parameters, and I will show you in the case of a certain patient later on. You see it on the schematic drawing and you see it clinically. Please, the next slide. So this was an introduction into periodontology. So if you don't diagnose periodontitis early, and periodontitis is a kind of a silent disease, it does not cause pain. And in the early stages, it does not cause discomfort. So it can be that people are affected by periodontitis, are suffering from periodontitis, but they do not suffer because they do not have symptoms. And if teeth get loose and if the gingiva recedes, then it's very late and possibly too late to save the teeth. So one point is very important: early diagnosis to prevent tooth loss, because tooth loss is the final stage of periodontitis. So please, the next slide. So let's plunge into Papillon-Lefèvre syndrome. So what is Papillon-Lefèvre? It is palmoplantar hyperkeratosis. So this is dermatology. We have these skin symptoms, but it's combined in most cases with severe periodontitis. And periodontitis in the primary dentition, which is very rare, but also in the permanent dentition. Next slide, please. Next, yeah. You may find hyperkeratosis of the skin at the knees and the elbows, various dysfunctions of the immune system, but only in 20% of cases. You may find mineralization of the dura mater, but only in 6% of the cases. This is not regularly found, however. Normally, we find a microaerophilic anaerobe microflora in the pockets of the people. And if it's tested for prior to treatment, in almost all cases, Aggregatibacter actinomycetum comitans is detected. And I will show you and explain you later that this bacterium plays, from my point of view, an important role in the pathogenesis of the disease. Next slide, please. So this is the case I want to show you. It's my oldest Papillon-Lefebvre case in 1995. When I was still in Heidelberg, he was referred to us. So these are the clinical images. It does not look really inflamed. The family dentist observed that the teeth, that there were gaps in between the teeth. This is these are permanent teeth already. This is unusual, and so he referred to an orthodontist so that the orthodontist should move the teeth. The orthodontist made a radiograph, and then he referred the boy to us into the to the dental clinic in Heidelberg, because the radiograph did not look so well. So next slide, please. So how do we measure? I explained to you before, how do we measure, or how do we judge periodontal destruction? You see this probe that is put between the tooth surface and the gingiva, and the probe, it's a probe that is scaled up to 15 millimeters. And normally, in healthy cases, the probe would reach in between gingiva and tooth for up to 3, maximally 4 millimeters. In this case, it's 7 millimeters. So this is a case with periodontal destruction despite the gingiva looking healthy. So a healthy looking gingiva does not exclude periodontitis, especially in the early cases in young patients. And we have 2 parameters that we measure. It's the pocket depth. This is to the gingival margin. And then there is the clinical attachment level, and this is measured to the cemento-enamel junction, where the cementum, where the enamel stops and the root surface begins, because the root surface normally is connected to the bone by connective fiber attachment, and so the cemento-enamel junction is the anatomical structure or landmark up to which the periodontal attachment under healthy conditions reaches. So you may judge or have an idea what normal probing pocket depth and clinical attachment would be when I show you later clinical data. Next slide, please. So that's a radiograph that was done by the orthodontist, and then the patient came to our clinic, and we did another one. And if you, so I'm sorry, because I cannot, I have no pointer now, but if you look to the mandibular incisors, the frontal teeth in the lower jaw, and if you look to the bone in the first molars, you see rapid bone loss from 1994 to 1995. So this is really uncommon. This is really dramatic bone loss in this young person. So there's periodontitis, very fast progression. Please, the next slide. And this is our clinical chart. It's the teeth, it's all permanent teeth. And you see there are rows of numbers. There's a T. The T means pocket depth, and there's a C. The C means clinical attachment loss, and a pocket of 11 millimeters depth this is that is dramatic periodontitis, very severe periodontitis. Normally, in an adult patient, you would say, okay, it is questionable to keep the tooth. And in the lower teeth, you see the very deep pockets, 11, 12 millimeters. When I discussed treatment with the mother of the boy, and you see the Roman 3s in the middle. This is mobility of these teeth. This is the highest degree of mobility that we know in teeth. So I had no hope for these teeth. And planning the treatment, I talked to the mother and I proposed extraction of these teeth. But the mother did not agree. So I treated these teeth as well. And there was a development that made it easier to treat them. Next slide, please. So this is the skin lesions of the patient. We referred the patient to the dermatology department in Heidelberg, of course. So we did the periodontal treatment. They did the dermatological treatment. They confirmed our clinical diagnosis by taking skin samples. It was yes, the hyperkeratosis was fitted to Papillon-Lefebvre. Next slide, please. So what is behind Papillon-Lefebvre? Next slide. It is a genetic disorder. It's quite rare. It's 1 to 4. No, one back, please. If 1 to 4 under 1 million of population, its inheritance is autosomal recessive. We find it more often in if there is consanguinity in parents. In the cases we have 30% of consanguinity. In this case, in the case I show you today, the parents were not related. But we have we had another pair of patients where the parents were first degree cousins. There is no preference for sexes, so it's the relation is 1 to 1, and the thing behind it, the defect behind it, is a mutation of the cathepsin C gene, and it's a loss of function mutation, or not one loss of function mutation, but many different loss of function mutations of the cathepsin C gene. Please, the next slide. And the cathepsin C is a lysosomal protease, a cysteine protease. It can be also found in the lung, in the kidney, in the epidermis, and possibly the cathepsin C plays a role in the keratin metabolism, so explaining the hyperkeratosis. In the neutrophils, cathepsin C activates serine proteases like cathepsin G, elastase, factor 8, and proteinase 3. And proteinase 3 is important because proteinase 3, next slide please, activates LL30. No, there's something, there's something missing. Okay, yeah, there we are. Proteinase C activates the bactericidal LL37. It's a catalysin, a human catalysin, and this molecule is active, antimicrobially active against most stems of aggregated Bacter actinomycetum comitans. And so these people are very very sensitive to infections with Agouti-Bacter actinomycetum comitans. At least this is plausible. And so all these lysosomal enzymes play an important role in phagocytosis. Next slide, please. So the medical history of the patient was, he was diagnosed by psoriasis vulgaris, but this is a misdiagnosed. The mother had psoriasis, but the boy had papillon-lefèvre. So this was our diagnosis because he had hyperkeratosis of the feet and the hands, and he had progressive periodontitis. Next slide, please. So we did also refer the patient to the hematology to look for major immunologic dysfunctions. They did not find any. So in the end, it's just the cathepsin C gene loss of function mutation. We have this confirmed. We made a test, and we found and published the respective loss of function mutation of the cathepsin C gene. Dermatological examination confirmed our diagnosis. The next slide, please. And now the question is how to treat. This is our microbiologic analysis. We did subgingival plaque samples, and we did hybridization. We did a gene probe analysis, and we did culture for Agouti-Bacter actinomycetum comitans. Next, please. And we found Agouti-Bacter actinomycetum comitans. So it was clear that if we treat it, we should use antibiotics, and this is normal. This is standard periodontal treatment in all our patients because the supragingival biofilm is creating gingivitis, and gingivitis is a precondition for periodontitis. So we try to improve oral hygiene. Next slide, please. It worked in the beginning, but it's an 8-year-old boy. So this is difficult to convince an 8-year-old boy to brush his teeth better. Next slide, please. Okay, and this was our treatment. The second step of treatment. I tried to clean the pockets under local anesthesia, but this did not work because the boy was afraid. Possibly he felt a little bit of pain, but he did not accept the cleaning under local anesthesia. So I decided to do general anesthesia, and in one visit I cleaned all the pockets, including the lower incisors, and we combined this with systemic antibiotics for 7 days. So first we had the cleaning of the pockets, so remove the biofilm and disrupt the biofilm. And the standard procedure for systemic antibiotics is amoxicillin and metronidazole. We have dosages for adults, but we had to calculate this down for the young boy. And we ended up with 250 milligram 3 times per day and 250 milligram metronidazole 2 times per day. This I made a conciliary with his pediatrician and asked the pediatrician whether there's anything would stand against this, because amoxicillin and metronidazole is heavy. That's a heavy antibiotic mix. We call it the atomic bomb against the subgingival microbiota, but he agreed in doing so. So next slide, please. Okay, parallel to our periodontal treatment. The boy was treated in dermatology, and he received oral retinoids, systemic oral retinoids, neotegazone. Since then, they started in 1995, and you see you have already improvement in the skin lesions. So the hyperkeratosis was under control. Next slide, please. So this is 1997. We did a new radiograph, and what you may notice, in the lower incisors, the frontal teeth, now the canines are erupting, and they push the incisors together. You may remember they had gaps before treatment, and shortly before treatment, now the canines erupt, and so the gaps become smaller, and this enabled me to splint the incisors. So you see the light material that is in between the teeth, that is composite, that to glue together the teeth to splint them. Next slide, please. So you see the situation, February 1966. You see now the incisors are pushed together, and below, that's the clinical view after general anesthesia and just non-surgical cleaning of the pockets. So deep pockets, 10 millimeters, 12 millimeters. And when the infection is gone, when the biofilm is removed, the inflammation disappears, and the inflammatory infiltrate disappears so fast that the connective tissue cannot regenerate with this speed. So we have large recession. Does not look nice, of course, and it was very sensitive to cold to cold drinks or so. However, he still has his teeth. So for such young people, patients, it's difficult. If they lose teeth and they have to attend school, you have to do prosthesis. So it is difficult for them to socially interact with their comrades. Next slide, please. Of course, we did microbiologic analysis again after treatment, and Agaricotobacter actinomycetum comitans was gone. What was good? So next slide, please. So at least he has taken, and this is 1996. This is the first assessment after treatment. It's a lot better, as you can see. However, it's not good. You see still some deep pockets. So what we accept after treatment is 5 millimeters. So that's the maximum as a treatment goal. However, the patient still has some pockets that are 6 millimeters. So there's still a little bit way to go. And BOP means bleeding on probing. These are the pockets that bleed if they are probed, and 34% is a high percentage of bleeding. Next slide, please. And this is to make a long story short. That's the newest X-ray of this patient. He is, in the meantime, he's 33 years old. He has finished university. He's working in near Nuremberg in Germany. 25 years after periodontal treatment, he has lost 2 incisors in the lower frontal region, but this was due to orthodontic treatment. He needed an orthodontic treatment after period treatment. They tried to move the teeth, but they were not quite successful, not totally successful, and so the gaps could not be closed. what you can see is that at the teeth that had erupted prior to treatment, there is still bone loss, but the bone has been stable. This is bone loss that happened prior to treatment, and all the teeth that erupted after treatment did not experience bone loss. So with this, considering this, treatment was successful, and after 25 years, he has most of his teeth left. Next slide, please. This is a clinical view. So you see the exposed root surfaces of those teeth that originally were diseased, of those teeth that have bone loss, but the gingiva looks quite okay. It's not perfect, but oral hygiene is not perfect. This is something he did not learn very well, but no recurrence of periodontitis. Next slide. You can see it in the clinical. Agrobacter actinomycetum comitans did not reappear anymore, so we could keep this microorganism out, which is a reason why this worked. That's my interpretation. I show you another case later where it did not work. Next slide, please. So now Agrobacter actinomycetum comitans, next slide, and regular supportive periodontal care. During the first month and years, he had visits every 6 weeks, and from that time on, now every 3 months. So this is really frequent supportive care to check for the pockets, to treat pockets, to retreat pockets, and to keep it it should read professional tooth cleaning. Sorry, that's a typo. Next slide, please. And finally, you can see the probing depth. That's very fresh. It's from August last year, a clinical examination. It's up to 4 millimeter pockets. Bleeding on probing 20%. So this is okay. After 26 years, most of the teeth still in place. So that's a success. Now I show you a failure. Next slide, please. And the failure, he has stopped taking levetiracetam. So this is a failure we know from the literature. These are 2 pairs of siblings with Papillon-Lefèvre syndrome periodontitis that were treated in the same way as I showed you before by a team in Würzburg. In the periodontal department at Würzburg, they did the same in these 4 patients, but all the orthos went from Würzburg to Münster after the treatment. So they did not continue supportive periodontal care. So the patients went back to their family dentists, and I will show you what happened. Next slide, please. These are 2 of the siblings, 2 sisters that we got contact to later on. And you see the microbiological examinations. The older sister has Agrobacter actinomycetum comitans, that's AA, all the time at the beginning prior to treatment. And the younger sister had it also. The treatment was the same as we did, subgingival instrumentation plus systemic antibiotics, amoxicillin and metronidazole. Next slide. Just 1 click, please. So that's metro and amoxi. However, you see it works in the younger sister, but it does not work in the older sister. Why so ever? Did she take the pills at all? Or was the genotype of Aggregatibacter actinomycetum comitans resistant? I don't know. The team, they did it. Next slide, please. They did another round of metro and amoxi, did not work. Next click, please. A final try. Now they changed from amoxi to amoxi plus clavulanic acid, but it did not work again. So I don't know why this did not work. However, in the paper, in the publication, you can read that the whole treatment could not eliminate or suppress Aggregatibacter actinomycetum comitans below detection limits. Next slide, please. So this is the older sister when we got to know her. Finally, she was referred to Frankfurt, and you see she still has 4 healthy teeth, and these are wisdom teeth. So she has lost at 15 years of age all teeth. This is a total failure of treatment. Next slide, please. That's the younger sister. She has left more teeth, but despite the wisdom teeth, all teeth are hopelessly diseased because there's no bone left to support the teeth. So she will lose all teeth also. And she's 13. She's 2 years younger. That's a catastrophe. And this is a clinical image. So it's inflamed. You see the tissues. On first sight, you can see there's something wrong. It's heavily inflamed. And you remember the X-ray, deep pockets, no bone left. What's the reason for it? Next slide, please. This is the younger sister. She has been reinfected by Aggregatibacter actinomycetum comitans. There was no treatment. She was not under proper control for periodontal disease. So reinfection and recurrence of disease. Next slide, please. And this is the older sister that still has Aggregatibacter, but this we knew before. So how do you deal with such a case? So we asked the surgical department, the Department of Oral Surgery in Frankfurt, whether they could consider dental implants as treatment. Next slide, please. And they did it in both sisters. However, that's the younger one. The younger sister is now attending medical school. She has understood what this type of disease means. Both sisters received 10 implants and a removable denture. The older sister has lost all implants in the meantime. A total disaster implant treatment in her, but the older sister does not comply with supportive periodontal or peri-implant care. Next slide, please. And this is the younger one. So she has the implants successfully for 9 years now because she is under supportive care, under control, and was not reinfected with Aggregatibacter. And now the last slide, please. So Papillon-Lefèvre syndrome periodontitis and its treatment. Next slide, please. PLS periodontitis can be treated successfully under the following conditions. Early diagnosis. If you come in too late, 50% or more bone loss around teeth, it will be very difficult to keep them. Periodontal treatment, anti-infective treatment, has to be performed comprehensively, and you should have an eye on Aggregatibacter actinomycetum comitans. If this bacterium is detected, it has to be treated with systemic antibiotics, and it has to be, you cannot eliminate it, or you cannot give evidence for elimination, but you should suppress it under detection limits, and then you have to see the patients narrowly scheduled for supportive periodontal care so that you can act if there is recurrence of Agarigati-Bacter, if there is recurrence of periodontal disease. And this was my presentation. Thank you very much for your attention, and thank you very much for, okay, this is my team. It's a postcard image from Frankfurt. It's the look from the clinic to our river, the mine, and this is my department on the department excursion in summer that we had.
Wow.
Thank you very much for doing the presentation. It worked perfectly. So
yes.
I'm very happy. Finally, we could manage.
Thank you, Professor. Any observations from our participants?
So treatment is possible. Sorry,
Professor. Yes, Dr. Bhumesh Kumar. Yeah.
Yeah. Thank you very much, Professor Peter, for nicely the illustrating of the syndrome, which is a multi-organ disease. So the multi-pronged approach is required. When any genodermatosis is required, we need to take the help of other specialities for the betterment and the quality of life of that patient, and not only that patient and their whole family. So once again, thank you very much for sensitizing us on this PLS syndrome with periodontitis.
Thank you, Professor. The second case of failure, what you say, sisters, retinoids are continued in them.
But supportive
retinoids.
No, the supportive treatment was stopped after the team in Würzburg left the university, went to another university, and the family dentist. I think the family dentist could not. A papillon-lefevre periodontitis is not something for a family dentist. This should be dealt by specialists. A family dentist could provide supportive periodontal care, but you see, you have to know what to do if there's a recurrence of disease. So under optimal conditions, this is treatment should be done in a university center, a specialized center, and of course it depends on the type the medical system is organized. At that time, when I treated the patient I showed you and the other patients were treated, the patients had to pay for supportive periodontal care themselves. It was not part of the medical insurance. In Germany, we have a statutory medical insurance that every citizen has to be part of, and until 2021, supportive periodontal care, periodontal treatment, active treatment was part of it. It was covered, but not the supportive care. And of course, if this may be too expensive for one patient or the other, and if there is nobody at the university clinic that is interested in the cases, that says, okay, we do it because we are scientifically interested, you don't have to pay so much, then there's nobody to manage.
Yes, right.
Yeah. One point related to the palmoplantar keratodermas, the initial, if it is a severe, initially we need to control with systemic retinoids. Once if it is controlled, the maintenance is mandatory, because any genodermatosis, the goal is to decrease the symptoms and decrease the signs and improve the quality of life. So here, once if you control with systemic retinoids, if the keratoderma, the severity will come down, then the maintenance is mandatory. Otherwise, recurrence is inevitable. So how we are going to maintain? So the topical keratolytic moisturizer, the urea-based moisturizers is necessary for the maintenance of palmoplantar keratoderma. Apart from that, so the hard shoes or the wearing of chappals better to avoid. The soft shoes, the trauma should be avoided on that. And not only that, the hyperkeratosis also, which will aggravate the secondary infections that can give rise to pitted hyperkeratolysis. So to overcome all this, so we need to the person he should use the cotton socks and frequently changing of cotton socks and daily washing of cotton socks and keratolytic moisturizers is necessary for the maintenance to decrease the severity as well as to prevent the severity of the palmoplantar keratodermis.
Okay.
Yeah. Dr. Bhumesh Kumar, have you seen the PLS cases in your experience?
No, I haven't seen. This is the first case I have seen. Thank you to Professor Peter for sensitizing us.
Yeah, we
And the-
we received cases from Nigeria, Kenya. Lot of 2 cases from Kenya, from different
yeah, but
tribes.
so we have our patients. So this is the case I showed you, and the two sisters. They are of German origin.
Okay.
We have another pair of brothers. They come from Eritrea. So they live in Germany, but the family descends from Eritrea. And the other pair of brothers that we treat, that we have contact to, they come from Morocco, from northern. So and Eritrea, Morocco is Northern Africa. And with Northern Africa, you may have the point of with Kenya as well, that you have very virulent Aggregatibacter actinomycetum comitans. There's a special clone that is endemic in Northern Africa. It's a GP2 clone. But when we did microbiological analysis, we had no means to distinguish. So we could only tell it's Aggregatibacter actinomycetum comitans, but we could not go deeper and look whether it is possibly GP2, but it's likely that GP2 in the Moroccan and in the Eritrean patients may have played a role.
Okay. How about the gene, cathepsin gene mutation?
I cannot have. We checked. It's published. We did for each single patient. We did a genetic analysis and analyzed the special genetic mutation, but I don't have it. I cannot tell you now by heart. I have to look it up. But it's in the publications. We have published the genetic mutations.
Right. Yeah.
So the only way basically you can treat if you get them early enough, these patients. In the Eritrean patients I got at age 3 and 5, and I treated the deciduous teeth, and then I had to extract some of them. The others I treated periodontally. And so I could provide that all the permanent teeth could erupt after treatment. And so they were not infected, and they could develop without disease. So if you are so early, you could provide the whole dentition and save the whole dentition. However, the family dentists have to have an eye for it. Normally, family dentists do not do not see or recognize periodontal diseases in children. That's the problem.
Yeah.
But it's difficult.
Yeah.
Okay.
Right. Thank you very much, Professor. You took a time to come and share your experiences. It will definitely.
It was a pleasure and it was an honor. So
yeah, thank you. Thank you very much. Dr. Bhumesh, you want to say something? Wind up?
Yeah, thank you, sir. Thank you very much.
Yeah.
Nice session. So many learning points.
Thank you.
Especially in genodermatosis.
Yeah.
So I wish to your center, the genome. So because the pediatric dermatology training center, which is under IADVL as well as government of Telangana, it is the only one center in Gandhi Hospital all over India. So any related to the pediatric dermatology, so we request any poor patients are there, please consider them to do some services.
Right.
okay.
Right. From Genome Foundation, whatever help in terms of genetics evaluation, we can we can help. There is no issues. Yeah. In fact, we have a we have to talk in terms of your national organization, IADVL. We have Telangana unit. We have some
Yeah.
understanding. This is these webinars are combined with Telangana, but you as a national figure, we would like to take it further. Okay, even rare diseases, there is a policy. But when I looked at the policy of the central government, there's no mention of, you see, the PLS case, it is a lot of expenditure is involved, even genetic testing and long-term treatment, and even specialties we don't have in one place. What you said, multidisciplinary, that type of condition systems we have to develop, and central government is keen on these rare diseases. They have a policy. Now we have to take up with your national organization, try to impress upon the government. Okay, we have a list of 50 rare diseases, skin diseases, and we can put forward. They have to recognize this. Mortality is not high, but morbidity, social stigma, the families, they won't go to any functions with these conditions. I have seen these two girls. One is girl from Nigeria, another is Kenya, 17-year-old boy. Okay, she fully covered and she refused to even open her mouth. Such type of situations, we need to impress upon the government. Otherwise, these are very costly treatments, multi-speciality involvement. Dr. Bhumesh, we should.
Yeah. Your all points are well taken. Even IADVL is working on rare diseases. So 27th January is the Rare Disease Day. Even IADVL is observing the Rare Diseases Day by conducting so many webinars all over India. So to sensitize the rare diseases, definitely we love to work in coordination with Genome Foundation. Definitely in the further future discussions, I'll put a word at the national level. So we are going to work together.
Sure. Thank you. Yeah. Yes, Professor, shall we say goodbye to you? But we should be in touch. Come sometimes to India.
I would like to
organize conferences. Yeah, we should come.
I would like to continue collaboration.
Yes.
Thank you very much for inviting me, and have a nice day, and
thank you.
Hope to see you soon.
See you soon.
Bye.
Yeah, bye. Bye. Thank you, Gargi. Gargi, vote of thanks.
Yeah.
Gargi will say things. Yeah.
Thank you, everyone, for joining in. Thank you, Dr. Eckholz, for the amazing lecture. The introduction, the case studies, they were very interesting and very informative at the same time. And the best part was that we could follow and understand what he was saying, since he was explaining it from his personal experience. We would look forward to many more such sessions with him and with others, and hopefully we can all learn more about this. Genome Foundation is very happy to conduct these webinars, and we hope to continue having your continued participation, everyone. Thank you for your attendance, and if you have any feedback, please do let us know, and we'll try to improve the event as much as possible.
Thank you, Gargi. Thank you very much. Bye, and Sharat Garu.
Thank you, sir.
Thank you. Bye, bye, bye.
Yeah, nice. Yeah,
You
very
are
nice
very nice to see
presentation
you.
information. Thank
You
you.